Okay, upper GI bleeding. Okay, so what is the most common cause of upper GI bleed? Most common cause is peptic ulcer worldwide. Most common cause of upper GI bleed is peptic ulcer. Okay, and what is the first investigation done in these patients? First investigation is upper GI endoscopy. Okay, so previously when I was preparing, there was a question which was very frequently asked. Like, there is a patient who is presented to the emergency with complaints of hematemesis, and on evaluation there is presence of splenomegaly. So what is the most, and this is the question, then the next line they'll write, what is the most likely cause for this upper GI bleed? The most probable diagnosis is esophageal varices due to portal hypertension. Okay, and sometimes they'll write there is a patient who has received in the emergency with complaints of hematemesis, full stop. What is the most common cause of upper GI bleed? The answer is peptic ulcer. And overall, simple question, the most common cause of upper GI bleed worldwide is peptic ulcer disease. So you will have to see the question very carefully, and then you will have to mark the answer. Okay, and then now there is a patient with upper GI bleed, and which investigation you will get it done? First we'll get the upper GI endoscopy done. Okay, now there are various type of risk stratification strategies which are asked nowadays in the exams. Now a patient has come to you in emergency, and the patient relatives are asking, or you yourself want to assess whether the patient is very high risk candidate, or you want the initial assessment to be done. So what is the strategy which is used for initial assessment when the patient is received in emergency? For initial assessment we will do Blatchford scoring. Okay, then we will do upper GI endoscopy. Okay, in this Blatchford scoring and bleed scoring. Okay, in these two scores we will do when the patient is first received in the emergency. Then we'll do the upper GI endoscopy, and we will, after this upper GI endoscopy, we will calculate a Rockall-Baylor score. Okay, this is very important to understand. Initially, when the patient is coming to you, you will first either do a Blatchford scoring or a bleed scoring, and after that we will do the upper GI endoscopy, and after this upper GI endoscopy we will go for calculation of the Rockall-Baylor score for prognostication. And this upper GI, on the basis of this upper GI endoscopy, we will calculate a forest classification which will predict for rebleeding. Okay, forest classification for rebleeding. Okay, so initially the initial assessment, Blatchford scoring, then along with Blatchford scoring we can calculate a bleed score also. Then we'll do upper GI endoscopy. On the basis of upper GI endoscopy we will calculate a forest classification score. Forest, we'll classify the bleed based on forest classification, which will help us in predicting the risk of rebleeding. And after that, finally we will be able to calculate a Rockall-Baylor score. And this Rockall-Baylor score is the best score or the most comprehensive score, because it also includes endoscopy findings. Okay, so now what is this Blatchford score? For initial scoring or for initial assessment, no endoscopy findings included, and The mnemonic to remember is push plus melena syncope plus cardiac or hepatic dysfunction. Okay. This push is pulse, then blood, urea, nitrogen, systolic BP, hemoglobin, and then presence of melena, syncope, cardiac or hepatic dysfunction. This is the Blatchford score. So whenever a patient is coming to us, we will be able to calculate a BP pulse of the patient, and we will be able to send some basic investigations like blood urea, nitrogen and hemoglobin. Along with that, we will be able to see whether the patient is having any cardiac or liver dysfunction or there is presence of any melena syncope. On the basis of these findings, we will be able to calculate a Blatchford score. Okay. Now, what is the bleed classification? Bleed classification, as the name suggests, it is itself having all the mnemonic, ready-made mnemonic is there in the bleed classification. This is ongoing bleeding, there is low systolic BP, there is elevated PT which is more than 1.2 times, erratic mental status, and there is unstable comorbid disease. Okay, now we have done the upper GI endoscopy, and on the basis of upper GI endoscopy, we will be calculating a class, we will be calculating a score, or we will be saying what is the finding on endoscopy, and we will classify the type of bleed based on Forrest classification. This Forrest classification is important. This type 1A is active pulsatile bleeding. Type 1B is oozing. Type 2A is non-bleeding visible vessel. Okay. This type 2B is adherent clot. This type 2C is black dot, and this type 3 is clean base. This type 1A, 1B and 2A is associated with high risk. When a vessel is visible or is bleeding, it is high risk. If there is high risk, then this high risk is of rebleed. So we will be able to calculate the risk of rebleeding on the basis of Forrest classification. So on the basis of Blatchford score and bleed classification, we will be able to prognosticate whether the patient is sick or not on the basis of upper GI endoscopy or Forrest classification. We will be able to identify how much is the risk for rebleeding. Okay, and this 1A, 1B and 2A is high risk for rebleeding. If there is adherent clot, it is intermediate risk of rebleeding, and this black dot and clean base is low risk. Okay. Now coming the next, which is the Rockall-Baylor score. Now how to remember? It is CASDE. Okay. So this E is obviously endoscopic stigmata. Of recent hemorrhage. Okay. or recent bleed. Okay. And now coming to C, this is comorbidity, then age, shock, and diagnosis at the time of endoscopy. So these two are what is the diagnosis and what is the endoscopic stigmata of recent hemorrhage, is there or not. So these two findings are of endoscopy, then the previous comorbidity and age, and the current clinical finding. So this is the most useful of all of them. Okay. Now there are three very important topics of upper GI bleed. Three important topics frequently asked. Regarding the upper GI bleed, regarding the duodenal ulcer bleed, I have already told you posterior one bleeds more, and the artery which is bleeding is gastroduodenal artery. The gastric ulcer bleeds from the left gastric artery, which is less common than the duodenal ulcer. Most common is the duodenal ulcer. This we have already discussed. Okay, and then the other topics which the other diseases which also lead to upper GI bleed are Mallory Weiss tear, then the Dieule-Foy's lesion, and gastric antral vascular ectasia or GAVE. Okay, these are the three other important topics which are associated with upper GI bleeding. And then there is a esophageal varices or the esophagogastric varices, which we will discuss in the portal hypertension topic separately. Okay, then this Mallory Weiss tear, I'll briefly describe these three topics and then we'll discuss them in detail. Mallory Weiss tear is basically a tear due to forceful vomiting or retching. There is a tear which is seen at the lesser curvature near the J junction, which is a mucosal tear or a mucosal oblique submucosal tear leading to a upper GI bleed. There is no perforation and it heals with medical management, no surgery is required. Okay, then coming the Dieule-Foy's lesion, there is a large pulsatile arteriole which is present at 6 to 10 centimeter along the lesser curvature, 6 to 10 centimeter from the G junction along the lesser curvature, large arteriole of 1 to 3 millimeter, which leads to a pulsatile bleeding. Okay, this is Dieule-Foy's lesion. And in gastric antral vascular ectasia, as the name suggests, there is a disorder at the level of antrum where vascular ectasias are noted, which are watermelon type, and they are associated with chronic iron deficiency anemia and watermelon stomach. Okay, so in these three topics, these two are associated with bleed and this one is associated with a chronic iron deficiency anemia. Okay, generally the investigation of choice for all three of them is upper GI endoscopy. Investigation of choice for all three of these is upper GI endoscopy, and the treatment of choice or the management is endoscopic treatment or endoscopic electrocoagulation. In case it does not heals with the endoscopic electrocoagulation, then the treatment is angioembolization. Okay, surgery is the least preferred or the third preferred option. In case if the angioembolization is not available in the facility, then we'll go for surgery. The primary treatment is endoscopic treatment or endoscopic electrocoagulation. Okay, so this is common for these three diseases and some basic details I have given. So now this is the endoscopic picture which is commonly seen in Mallory Weiss tear. Don't call it Mallory Weiss syndrome. Okay, always call it a Mallory Weiss tear. This way you will always remember that it is a tear, not a perforation. Okay. not a perforation. This is not a perforation. This is only a tear, or it is a mucosal oblique submucosal tear. Okay. Whereas Borav syndrome is seen in esophagus. It is spontaneous esophageal perforation. Okay. So that is a spontaneous esophageal perforation. And this Mallory-Weiss tear is just a tear and is not a perforation. It is associated with GI bleed. Okay. So this Mallory-Weiss tear is a partial tear. At the level of cardia, it is a longitudinal tear, as you can see in the diagram. Cardia or just below G junction. Sometimes they give the option as just below G junction. Sometimes they give the option as cardia. Okay. And it also occurs because of repeated forceful vomiting or retching. Generally what happens is, after intake of alcohol or after a heavy intake of alcohol, generally it happens in males, there is a lot of retching and lot of repeated forceful vomitings, and after that there is a bleed. Okay. This bleed is generally because of this tear, which is Mallory-Weiss tear. Okay. So clinical features, in majority of the patients, there is only a minor bleeding and nothing is to be done for the bleeding. In massive bleeding is seen in 20% of the patients, and for this massive bleeding we will go for upper GI endoscopy and electrocoagulation. Now a question: for Mallory-Weiss tear, what is the most common artery which is responsible? Is the left gastric artery. Okay, investigation of choice, upper GI endoscopy. Treatment of choice, conservative management. If not responding, then we should go for endoscopy and electrocoagulation. And if not responding, we will go for angioembolization. If not responding, then we will go for surgical closure. Okay. Now, an important topic, whether we will use a Sengstaken-Blakemore tube or not. Sengstaken-Blakemore tube is used in massive bleeding in Mallory-Weiss tear. True or false? We all know Sengstaken-Blakemore tube is used in portal hypertension to stop the emergency bleeding in esophageal varices. Yes, but this Sengstaken-Blakemore tube is not used in Mallory-Weiss tear. Why? Because this is arterial bleed, and in case if we are using a Sengstaken-Blakemore tube and we are inflating the balloon, then this will increase the tear and will convert a partial tear into a full thickness tear. Also, this is arterial bleed, whereas in portal hypertension there is venous bleed, which is easier to control with less amount of pressure, but this arterial bleed is difficult to control with less amount of pressure. So Sengstaken-Blakemore tube is not used in patients with this Mallory-Weiss tear. Okay. Now, what is this? This is Dieulafoy's lesion. This endoscopic picture is important. Okay, this endoscopic picture is of Dieulafoy's lesion, in which there is large arteriole which is visible. Okay, what is this happening here? Active pulsatile bleeding. What is the classification? According to Forest classification, this active pulsatile bleeding is for type 1A Forest. Okay. And this type 1A Forest comes in high risk of rebleeding. So there is a very high risk of rebleeding in duolephoid lesion, and we should go for early upper GI endoscopy and electrocoagulation in these patients. Okay. Now we will discuss the duolephoid lesion. There is active pulsatile lesion. Okay, there is active pulsatile lesion. There is presence of large arteriole of size 1 to 3 millimeter, which is generally present at this location. This is 6 to 10 centimeter below G junction along the lesser curvature. So this is present 6 to 10 centimeter below G junction along the lesser curvature. It is placed just below mucosa. Just below mucosa. So if a person is very casual while doing endoscopy, there is possibility of missing the lesion in case if there is no active bleeding at the time of upper GI endoscopy. So this is very important. In case if there is no upper GI, no bleeding, then there is a possibility of missing this lesion at the time of endoscopy. Okay. There is high rebleeding risk, Forest type 1A, high rebleeding. There is massive bleeding because it is arterial. And why there is massive bleeding? Because the gastric acid, it damages the arteriole wall. Okay. It is not the artery, it is the arteriole. So gastric acid damages arteriole wall. Okay. Which leads to rupture of the arteriole and massive bleeding. Now what is the clinical feature? Clinical feature is obviously hematemesis. If there is massive hematemesis, there is presence of hypotension. Okay. And what is the investigation of choice? Obviously upper GI endoscopy, already told. What is the management? It is same, endoscopic electrocoagulation. If not responding to endoscopic electrocoagulation, then we will go for angioembolization, and then if not responding to angioembolization, then we will go for surgical ligation. Okay. Now, next topic, what is this finding? Now there is a patient who is presenting with chronic generalized weakness or features of anemia. On evaluation, there is iron deficiency anemia, and on upper GI endoscopy, we see this kind of finding. What is the diagnosis? So the diagnosis is watermelon stomach, or GAVE. This GAVE stands for gastric antral vascular ectasia. Okay. So in the stomach, in the antrum of the stomach, there is presence of vascular ectasias. So the pathology is vascular ectasias, and in antrum there is, the most common site is antrum, and there is presence of watermelon stomach on upper GI endoscopy. Watermelon stomach. Why there is watermelon stomach? Because of parallel arrangement of vessels. Which we can see here. This one, this one, this one, this one. There is parallel arrangement giving the appearance of watermelon like appearance, watermelon stomach. Okay. Now coming on to the clinical features. So it is seen in elderly females. Elderly females. There is presence of chronic occult bleeding. which leads to anemia, fatigue. Now one important finding is that 25% of these patients, they have portal hypertension or chronic liver disease features. Okay, so 25% patients, they have CLD or portal hypertension. Okay, this is very important. Now what is the diagnosis? Diagnosis is upper GI endoscopy, but upper GI endoscopy may, even if we'll be able to see the watermelon stomach, then we'll have to take a biopsy, and on biopsy we'll have to demonstrate the presence of vascular ectasias. Okay, then only we'll be able to label it as GAVE. So upper GI endoscopy and biopsy, and management is same. I have already told you, endoscopic electrocoagulation. Okay.